or iliopsoas in this case. Iliopsoas, rectus femoris, pretty much going to test together. If you look at your paper, if you jump ahead, rectus femoris is under the quadriceps list. It is tested as a knee extensor. You could test it as a hip flexor. The difference here is just going to be whether you sit up or you lean back. That's basically the only difference, kind of like what we talked about in knees. You have a length tension issue with crossing both joints. So the hip flexors can be tested as a group, iliopsoas and rectus together. If you wanted to differentiate them out, you would just lean back a little bit. Which one's which? How many people say leaning back is iliopsoas? How many people say leaning back is rectus? How many people are fence sitters?
I'm undecided.
Oh, fence sitters. All right, I'm gonna go with leaning back is more iliopsoas. Why?
Go ahead, yay, go. Tell everybody
Because
why
of
you
two joints?
Yeah. Why does it take the rectus out? Because you're lengthening it more.
Over.
You lean. It's already lengthened over the knee. If you lean back, you now lengthen the rectus more. So it's at a mechanical disadvantage. Not that it's completely exclusive. You're still testing both, whether you're sitting up or leaning back. But you get a little bit more iliopsoas leaning back because the rectus is at a mechanical disadvantage because it's lengthened. It's already lengthened here, so you're lengthened here. So by description, it has the psoas setting up, and you can test it that way. But guarantee there's going to be some follow-up question. How do you differentiate that between the rectus? If I wanted to test the rectus at the hip, say, oh, if I tested the rectus, I'd keep them setting up. If I wanted to test the iliopsoas, I'd have them leaning back. Everybody okay with that? Okay. The iliopsoas, like the subscapularis, this is probably one exception where I'm going to position them different to palpate than I'm going to position to test, because I think it's very hard to palpate the iliopsoas with somebody sitting, because everything's kind of compressed. I like palpating iliopsoas supine. Slide up here. You can stay right there if you're comfortable. Okay, so just to remember the psoas part between the ASIS and the umbilicus, kind of going in and down. Pick your knee up. Right there. Come back up. The iliacus part, just right in off of the iliac crest, right off of the ASIS. Okay. I just say, if you want to palpate setting, go for it. I just think when people are setting up, especially because they're supposed to be in a posterior pelvic tilt, it kind of collapses everything, and it's a lot harder to palpate sitting. Especially if you have somebody like me that has a really long rib cage. The space between my rib cage and my pelvis is about this big when I'm sitting. So that makes it really difficult to get in there and palpate around. Okay? So kind of like the subscapularis, positioning for palpation is different than positioning for testing. Okay?
I was gonna say, so if I could do that while I'm laying down, can I clearly do a full range of motion against
No,
gravity
because
by that?
you may have just contracted. All I wanted to do was see if you could check
Okay.
so I could feel it, make sure I was on the right spot. I didn't
Okay.
realize how much of that you did.
Okay.
So even if you didn't lift, it's
Okay.
check enough for me to feel it. So I'm not looking for testable information from here.
Okay.
I just did it to kind of verify that I was in the right spot.
Okay.
Okay, go ahead and sit back up. Okay. So, if it's iliopsoas, you might want to have it lean back a little bit. Stabilization here, paper says opposite pelvis or opposite side of the hip. Sometimes people, if I have a leaning back, have kind of fixed stabilizing your trunk because she's holding down with her hands. But if you have people use their hands to cheat, like you push down with your hands to make your leg lift, then I'm going to take away the hands, so I'm going to make her do this, and in which case now I'm going to stabilize here. So my stabilization might vary. It might be here, it might be here, depending on how they try to compensate. You'll see lots more compensation in the lower extremity than you will in the upper extremity because the muscles are bigger. So if there's weakness, they really try to compensate, and the compensations are a little bit more obvious. And especially with the hip ones, the trunk tries to take over. And so you'll see lots of weird trunk stuff. So you gotta really make sure the trunk is stabilized well. If you have them leaning back, you kind of self-stabilize, so you can go ahead and just stabilize where you should be right here. And then all you're gonna ask them to do is lift your knees to the ceiling. Good. And they don't have to be like all the way up to their belly. Obviously, just what they can do, you know, is that as long as they're clearing, I'm fine with that. I mean, there's not like a huge range, because really, what's normal range of motion of the hip? Flexion range of motion of the hip. How many degrees of motion is normal flexion?
125 to 130.
It's about 120, 130, depending. You're already almost 90 to 100 right here. So she just needs to clear her thigh. That's all I'm worried about. I don't need her to be way up here. All of that is gravity. It's not playing a role. So just making sure they clear their thigh is basically the deal. Stabilize here, and then I would be standing. I'm just not going to because my knee hurts. And push here. Okay, this is where you guys, I actually am going to stand because you guys, a lot of you people that are little are going to maybe want to put your patient a little bit lower so you get a little bit better mechanical advantage, because these are strong muscles. Hip flexors are strong muscles, and so you want to make sure that you give yourself as much advantage as possible. Hold that. Okay. Rectus, if I want to differentiate, just sit back up. But in sitting, she's still in a posterior pelvic tilt, so you don't have to tell her to sit up nice and tall. You want her to just sit like she normally does, because if you tell people to sit like they normally do, they automatically sit in a posterior pelvic tilt. So if for some odd reason you have somebody that sits in an anterior tilt, pelvic tilt, put them in a posterior pelvic tilt. But most people naturally, when they sit, if you don't cue them, will sit back into a posterior pelvic tilt. So same deal here. You can either stabilize here or stabilize here. Lift your knee. Hold that. Good. Obviously, I didn't do palpation of the rectus femoris, but it's all the way up to AIS. AIIS to the pelvic tendon. Okay, gravity minimized gets a little bit tougher because it's side lying. And this is one where slide boards don't work. You can really kind of figure that out. So you have to support the weight of the entire leg. So be careful here with your positioning, because I don't want her so far over the table that I'm doing this. But then again, so standing behind her or in front of her is kind of personal preference. I like in front because I can move with the motion, versus if I'm behind her as she flexes her hip, I'm going to be doing this. And again, probably not the best body mechanics. So I'm going to have her slide a little bit closer to me. Test leg on top. I'm going to make sure I have the weight of the whole leg. So this might, if it's a big leg, maybe I'm doing this. You know, do something to keep yourself safe. Maybe bend my legs. And then what I want you to do is you're just going to bring your leg forward towards me. There you go. Good. Huh? Knee doesn't have to be straight. Knee can just be relaxed. I don't care what the knee does. Okay? And then I can add resistance. I'll just slide this hand a little bit. If I want to try the 2+ thing, I can just add the resistance there, and I still have the support of her thigh. Okay? So that's true for iliopsoas and rectus. There's not a differentiation there. The key here is that you keep them up on their hips, because what people will do is they'll tend to rotate back. And she's a little bit sooner to be up here. Make sure they're stacked and laying flat. I let her set up so she could see, but you want her to be here. So I can stabilize here just to make sure she doesn't roll off the table, and be here, and still be, you can relax your knee, still be here. So when she goes through the motion, I can just move with her. But these, especially these lower extremity ones, I would practice on all different body types. Because little Shari and big Marlin are a huge size difference. You gotta figure out how to support his whole leg with your little body. Yeah, you gotta do it. So you gotta, and keep yourself safe. So you gotta figure out the right mechanics to make that work. We are not blessed with tables that rise up and down. Hopefully you get to a clinic. I did that yesterday. I had a 300-pound patient, huge dude, comes in this scooter that probably weighed 300 pounds. It's like a Cadillac scooters. Fractured his femur, and does not move very well at all. And I had a very difficult time even evaluating his leg because it took all of my might. Maybe that's where I hurt my knee. My knee is just funny, but his what? You just tell me I have arthritis. Is that what you're saying?
Yeah,
but the weight of his leg was probably close to 100 pounds. So you just gotta make yourself safe. So kind of play with that as far as positioning and table. You don't have the table height option unless you use the traction tables, and then you can play with the table height. But you gotta do with what you have. And a lot of times in low budget clinics, these are all you have, because these tables are way cheaper than the ones that go up and down. So questions on hip flexors. Let me do sartorius to kind of finish up this group. So I'm gonna have you sit back up. Okay, so the funky thing about sartorius is you don't necessarily stabilize with sartorius because you have to use both hands for the resistance, because you have to resist all three motions. So palpation wise, ASIS all the way down to pes anserine, anterior medial tibia. Everybody good? Its motions are flexion, abduction, external rotation. So basically what you tell your patient to do is I want you to take your right heel and touch your left knee. That's the motion. When they go there, when you go there, I want you to stay there. I need to resist into extension, adduction, and internal rotation. So I need both hands to do the resistance piece. So it's naturally stabilized because I'm kind of it's a counter force thing. So she's up here. This hand is going to go into extension and adduction. This hand is going to do the internal rotation piece. Okay, so go back up there. Hold that. Ready? Go. Okay. Good. Gravity minimized is supine. It's kind of like the coordination test. I want you to take your heel and run it up your left shin. That's it.
I did it.
And then if I needed to add manual, I could do that. Kind of the same deal. I could be here as she goes up and just give her some resistance as she goes. So again, there's a little oddball because there's not a stabilization hand. Both hands are doing the resistance to get all of them. Okay? So iliopsoas and rectus sitting against gravity, sideline gravity minimized. Sartorius sitting against gravity, supine gravity minimized. Good?